CMR, particularly in relation to tissue characterization and the diagnosis of an important category of cardiac diseases, which is myocardial diseases, cardiomyopathy and myocarditis. Some of you might think that MRI is a recent method of investigation. It's relatively recent, of course, but it has been the first MRI was for a finger taken by Sir Peter Mansfield and Paul Lotlenberger. This was in 1977. They were awarded the Nobel Prize in 2003 for that. So it's not absolutely very recent like anyone who might imagine. It's an established technique, of course. We will go through a variety of attributes of the CMR, as well as the capability, unique capability of CMR in the diagnosis of various conditions, emphasizing its role in tissue characterization and cardiomyopathies. As you see on the right side of this screen, we have a classification, an etiological classification for cardiomyopathy, ischemic by far the commonest, but valvular stress-induced infiltrative inflammatory muscular dystrophies, toxins, and peripartum, and others. And as well, we have a morphological classification, dilated, hypertrophic, restrictive, right ventricular, and unclassified. Probably MRI has a unique capability among other investigations in cardiology to diagnose both aspects of cardiomyopathy, the etiological aspect as well as the morphological aspect. So this is the subject of tonight. And in the discussion, we can move to other areas of CMR if the time allows. So in this presentation, I will talk about the assessment of cardiac function, left ventricular volumes, ejection fraction, regional wall motion abnormality. Of course, CMR is the gold standard in estimation of volumes and ejection fraction. We are going to talk about properties of protons. A proton is the nucleus of hydrogen, so it has many names. You can call the proton, you could call it proton, you can call it a spin. A spin is a proton, is a hydrogen nucleus. They are not exactly the same, but they are used in the area of CMR as synonymous terms. And the role of the properties of protons for tissue characterization. We are going to talk almost everything about gadolinium. Gadolinium is a rare earth element in the bottom of the periodic table. And we are going to talk about terms like T1, T2, T2 star, and myocardial mapping, which is the future of the CMR. Now, if you look into this picture, this is actually a short axis view of the left ventricle going from the base of the left ventricle at the level of the mitral valve and going all through the left ventricle, cuts down to the apex of the left ventricle. All of these are taken in almost 12 seconds. If you can imagine that at Mansfield time, the first MRI for a finger took 5 hours. So we went far more advanced than ever before, as usual. So this is the way the left ventricular volume is can be calculated using CMR. The advantage, actually, there are many advantages. Number one, the apical foreshortening, which is very common finding in echocardiography, is not encountered here. The role of the operator is not as much as in patients as in echocardiography, but much more important, we have no assumptions like using formulas for the prolonged ellipsoid, which is used sometimes in echocardiography and sometimes and always in ventriculography, contrast ventriculography. We can trace the endocardium and the epicardium. We can trace it in the systole and in the diastole. The machine does that quickly. And at the same time, using the Simpson's formula, we can calculate the volume of each segment and add them together. So there is no geometric assumptions which introduces error in the calculation of left ventricular function and left ventricular volume by other measures. So in systole and diastole, from that you can calculate the ejection fraction. You can calculate also the mass by subtracting the epicardial pacing in systole and the diastole from the epicardial pacing, from the endocardial pacing, and multiply by the specific gravity of the myocardium. Of course, that's variable in all the conditions which are listed on the left side of the screen, including myocardial infarction, heart failure, congenital heart disease, and other situations like that. So this is this is the reason why the CMR is considered the gold standard in estimating volumes, mass. Now, we will start with a case to illustrate the value of CM's a 69-year-old woman, about 160 cm. She's having atrial fibrillation and hypertension. She suffered 3 episodes of syncope. The ECG, when she was in sinus rhythm, revealed the first-degree AV block. Obviously, she is now in atrial fibrillation, and she has lateral T-wave inversions. So this is the CMR. You will find this is a 3-chamber view. This is the left. I hope the pointer is seen clearly here. This is the left atrium. This is the left ventricle, and this is the aorta. This is the 2-chamber view: the left ventricle, the left atrium, the anterior wall, and the inferior and posterior wall. And this is the apical 4-chamber view. And then starting from here, you will find shortcuts, short axis views from the base of the heart going up to the apex of the left ventricle. So having considered these pictures, the question is, what's the diagnosis? Is it wall motion abnormality involving the cardiac apex? Is it amyloidosis, syndrome X with microvascular ischemia, apical hypertrophic cardiomyopathy, arrhythmogenic right ventricular dysplasia? So the correct answer here, if we go back to the pictures, if you look into the apex here, the apex is much thicker than the base of the left ventricle. So we know that the left ventricle thins out as you move from the base of the left ventricle towards the apex. So here is exactly the opposite. As you move towards the apex, there is much thickening of the apex. The thickness of the left ventricle in the apex is more than 15 millimeters, and the ratio between the thickness of the left ventricle at the apex and the left ventricle at the base exceeds 1.3. So these are the MR diagnosis of diagnostic criteria for apical hypertrophic cardiomyopathy. Now, if you look into this, this is the criteria again: apical width more than 15 millimeters, and the ratio between the apex and the base is more than 1.3. And you have mild, moderate, and severe degrees. So as you look here, you will find this is the septum. As you move in the moderate and the severe cases, the septum, instead of thinning out towards the apex, you will find it is thickened, the same with the lateral wall. So this is an important finding which put the diagnosis of apical hypertrophic cardiomyopathy. Now this is another case. Look at these pictures and what's the diagnosis. Now, this is a coronal view. Here is the left ventricle. Here is the right. This is the left ventricle. This is the right ventricle. This is the aorta. This is a part of the pulmonary artery. And this is an apical 4-chamber view. This is the left ventricle. The septum is free. And if you look here, this is non-compaction. Very prominent trabeculations. We know that non-compaction is nothing but a specific phenotype. It's not a cardiomyopathy by itself. It can be associated with so many cardiac conditions. It involves the free wall of the left ventricle essentially, usually spares the septum. The right ventricle may be involved to a lesser degree, as in this patient. So if you look into the questions, hypertrophic cardiomyopathy, myocarditis, amyloidosis, the correct answer is non-compaction, or sarcoidosis, no, it's non-compaction. So the diagnostic features of non-compaction in MRI, usually we make the measurements at end diastole. In the echo, usually we make the measures at end systole. The ratio for end diastolic CMR criteria is 2.3, and for the echo is 2. Obviously, it differs slightly in infancy, childhood, and adults, but usually you find whether this is a specific cardiomyopathy that results in a specific outcome, that's not well established, but the presentation can vary from completely asymptomatic up to sudden death. Now, the next case is this condition. Here, the MRI has a unique capability of showing the right ventricle. In the echocardiogram, the sternum is standing in front of the right ventricle, obviating a clear picturing of the right ventricle. In MRI, as well as in CT, this obstruction of the septum is nullified. So we can see the right ventricle in this coronal view. This is the right atrium. This is the right ventricle, the outflow tract of the right ventricle, the root of the pulmonary artery, and the branches of the pulmonary artery. And this is the apical four-chamber view. Now, the Hopkins criteria usually rely on the presence of right ventricular dilatation, as well as the presence of dyskinetic areas, particularly in the triangle of dysplasia involving the right ventricular outflow tract, the inflow tract, as well as the apex. And the criteria emphasize that the right ventricular end-diastolic volume should exceed 110 milliliters in men and 100 milliliters in women. So the presence of fat, which is usually located in the outflow tract of the right ventricle, because it's the pathological counterpart of this high-density MRI finding, the presence of fat by MRI is not a criteria. The presence of fat by biopsy or histopathology is the major criteria. But no one is doing a biopsy for right ventricular dysplasia because these areas are thinned out and they are prone to perforation if you biopsy them. So the reason MRI is not used to detect fat and consider it is one of the criteria for the diagnosis of the condition is that normally fat is present in these conditions, and with fat suppression, you cannot get a differentiation between what's normal and what's abnormal. So we rely essentially on abnormalities in the right ventricular morphology, the presence of areas of dyskinesia, the presence of right ventricular dilatation, and you know that this is an autosomal dominant in Nexus and Carvajal. You have an autosomal recessive with woolly hair and palmoplantar hyperkeratosis. So now how the MRI can identify tissue characterization. Now let us take a simplified overview of how the MRI works. If you are sitting in the room, then your protons or the hydrogen ions are spinning, يعني بتلف حوالين نفسها in different directions. But if you go into the pore of the magnet, by the way, there is no magnet. It's just a group of coils, and this group of coils undergoes super cooling to minus 155 degrees using liquid nitrogen and liquid helium. And this degree of supercooling results in passage of electrons in the coils at a very fast speed, and that's the reason we get a magnetic field. This magnetic field can vary from 1 to 1.5 to 3 Tesla. And human beings, we are not using more powerful magnets, although there are 13 Tesla MRI, but they are used in geology to identify metals, not in human studies. So if you allow the patient to go into the pore of the magnet, what happens is that all this spinning, which is haphazard, gets locked in one direction. Some of them are going from north to south, and some are going in the opposite direction. Now, if you apply a radio current, a radio FM waves, then what happens is that you get tilting, you get tipping, you get malalignment, you get tilting of the protons from the axis in which it was present when the patient was put in the pore of the magnet. Now, this tilting will occur in the y-axis, that's in the vertical axis, as well as in the horizontal axis. And when it tilts in the horizontal axis, it dephases. So the spins get separated from each other. That's the important point. And then what happens is that we switch off the FM radio waves, and under these circumstances, the spins or the protons will go back. They realign in the horizontal axis, and then they realign in the vertical axis. So they coalesce together in the x-axis, and then they build up electromagnetic field in the y-axis. Now, this is called the relaxation. The relaxation which occurs in the vertical axis is called T1. The time it takes for relaxation to occur after we switch off the FM radio waves in the vertical axis is called T1. And in the horizontal axis, the dephasing and the realignment of the protons from the dephased state is called the T2. T1 and the T2 are tissue characteristics. They are not sequence that are used in the MRI. It's different. The sequences which we use in the CMI are related to T1 and the T2, but T1 and the T2 are tissue characteristics. Anything which diminishes the time of T1 will make a bright picture. What diminishes the time of T1 is gadolinium. So we give gadolinium to shorten the time T1, and under these circumstances, you get a bright pictures. On the other hand, anything which lengthens the duration or the time of T2 is going to give a bright picture. What is going to lengthen the time of T2 is water. So if you have inflammation, if you have acute recent myocardial infarction, water is there because of increased capillary permeability under these circumstances. It elongates T2 and produces a bright picture. So they are opposite to each other. If you shorten T1, you get a bright picture. If you lengthen T2, you get a bright picture. So remember that T1 and the T2 are different characteristics of the tissues. Now, at the same time, what is it? So when the spins move again in the direction of the magnet because you switched off the FM radio waves, then energy is liberated. This energy is taken by gradient wires, which is called antenna. And these waves, when they are taken by the antenna, they are changed by the Fourier transformation equation into picture. I have been asked several times, what's the Fourier transformation equation? It's a method, it's a mathematical method by which we change waves into lines. And these lines are the pixels from which the picture is formed. So to summarize the situation again, haphazard spins go into the pore of the magnet, lock in a special position, apply radio frequency current, they tilt in the vertical direction as well as in the horizontal direction, switch off the FM current, and under these circumstances, they go back into the pore at a certain time, T1 and the T2, releasing energy, which is picked up by the antenna, and the antenna by Fourier transformation creates the picture. So this is in a very, very, very simplified way how the EMR is working. Now, the simplest way of by which tissue characterization occurs with CMI involves the differentiation of fat from water. Fat the hydrogen atoms are linked to carbon, but in water, the hydrogen atoms are linked to oxygen. So as a result of this difference, you get differences in the degree of opacification or attenuation of the magnetic current. So as a result of that, you will find that the fat is white, very similar to the subcutaneous fat located here, whereas the myocardium, which is rich in water, is gray under these circumstances. So that's why, because the hydrogen atom is linked to carbon in fat and is differently linked to oxygen in water, and this is the reason why we get a difference in the degree of signaling between fat on the surface of the myocardium and the gray tint of the myocardium itself. So what is gadolinium and what it does? Gadolinium is a rare earth element, and what it does, it shortens the time of T1. And by shortening the time of T1, as I just alluded to, it intensifies the signals and it appears bright. How does it shorten time of T1? It just coalesces the molecules of water together. So in short, gadolinium allows water to be seen better. So if you have an inflammation, if you have fibrosis, if you have anything which is producing edema, like acute myocardial infarction, all of these conditions, you get much more water. If you inject gadolinium, the water molecules will coalesce together and produce a high intensity signal and appears as bright. As I mentioned, anything which shortens T1 produces a bright signal, and anything which lengthens to T2 produces a bright signal. What shortens T1 is actually gadolinium, and what lengthens T2 is water. No, so gadolinium actually is administered in the form of a chelated compound. And the reason we inject gadolinium as a chelated compound, not as a free gadolinium, to avoid when it's given in a chelated compounds, it evades the tissues and circulates in the blood and the capillaries. It produces allergic reaction in a very small minority of patients, 1 in 20,000, 1 in 40,000. But it has a metallic taste, which is appreciated by 1 in 20 to 1 in 40 individuals. It can produce sometimes reflex vomiting. This is not an allergic reaction. This is a direct effect of the gadolinium on the chemoreceptor trigger zone in the floor of the fourth ventricle. If you inject gadolinium when the glomerular filtration rate or the estimated glomerular filtration rate is below 30, particularly below 15, it produces nephrogenic systemic fibrosis, now almost unencountered because every center knows that it's contraindicated to give gadolinium or gadolinium chelates when the GFR is that low. This is a systemic sclerosis-like condition in which there is fibrosis in the subcutaneous tissue as well as in the myocardium and various tissues. There has been reports about the accumulation of gadolinium in the brainstem in patients with cancer metastasis and taking several times double dose gadolinium, but so far there is no clinical adverse outcome from this accumulation, but the FDA is instructing everybody to watch for that. There is now no non-gadolinium stress agents like supermagnetic iron oxide nanoparticles. They are replacing gadolinium, but still gadolinium is more widely used than anything else, and the other non-gadolinium compounds are usually used for research reasons. Now, if you inject gadolinium, it circulates in the blood, goes to the heart within the first minutes. This is the first pass perfusion. And as I told you in T1 imaging, what we call bright blood image, it lets the myocardium to take the gadolinium, and as a result of that, it appears white. So this is the perfusion of the myocardium. This is the gadolinium inside the ventricular cavity. But look at this dark area. This dark area is an area of ischemia, whether the patient is having ischemia at rest, or this is a part of adenosine CMR test, but this is an area of ischemia. Now we let this go for about 5 to 10 minutes and take another picture, and this will show you what we call a late gadolinium enhancement. Because this area of ischemia, if there is any evidence of fibrosis because it's long-standing, or myocardial infarction because it's recent, then the space between the cells is widened, and so the washout of gadolinium is delayed and it stays in this area. So this is an area of infarction located at the apex, and probably part of the right ventricle is involved as a. So this is what is called delayed gadolinium enhancement. So we have early gadolinium enhancement here. We have an area of ischemia. So as you see here in coronary artery disease, you can detect ischemia, you can detect infarction. Now the important point about MRI is a huge capability to detect small subendocardial infarction, which cannot be seen with any other modality. It can detect an infarction as small as 1 gram of tissue, or less than 1/1000 of the left ventricular mass, and its resolving power is 20 to 40 times the nuclear power to detect myocardial infarction. So these are major advances in the field of ischemic heart disease for the MRI. Now, if you look at this short axis view, this is the gadolinium inside the ventricular cavity, and this is the early perfusion in the first minute. Now, after 10 minutes, 5 to 10 minutes, you can see that the perfusion of the myocardium is gone, but at the same time, there is some late gadolinium enhancement or delayed gadolinium enhancement in this area in the lateral wall. Now, if you look at this as a pie, and these are different sectors of a pie, then this area, which is labeled A here, is the part which is infarcted of the subendocardium. You compare A to A and B, and this is the most precise method by which you can quantitate the amount of myocardial infarction. In any other modalities, we compare A with the adjacent viable segment, but here you are comparing A with the adjacent part, which is of the same segment. So if you look into A here, then you can say that this infarction is taking about almost 40% of the left ventricular wall in that location. So the outstanding capability of detecting exactly the amount of infarction and its relation to the surrounding myocardium, as well as the small amount of infarction that can be detected by CMR and can be missed by other modalities is obvious from these slides. Now, if you look into this diagram, which is a very important diagram, if you look into the x-axis here, this is delayed gadolinium enhancement of 0, no delayed gadolinium enhancement, 1 to 25, 25 to 50, 50 to 75, and then 75 or 70 to 100, 75 to 100. And on the y-axis is the capability of reviving myocardium. You get after vascularization, you get the myocardium contracting again. So in viability studies, if you have a 0 late gadolinium enhancement, this means that the possibility of having a viable myocardium and contracting myocardium after 6 months in this study is very high. Same applies to gadolinium delayed enhancement, taking 1 to 25% of the myocardial thickness. But look, if you exceed 50%, there is very minor possibility that you get salvage of this myocardium by any method of revascularization, whether we are talking about PCI or surgical revascularization. Now, if you have anything between 1 and 50, this is an intermediate grades, then you ought to go or jump to another method, which is dobutamine imaging, whether dobutamine echocardiography or dobutamine MRI. And under these circumstances, in these areas which showed delayed enhancement of intermediate degree between 1 and 50, if they are thickening with dobutamine imaging, then the possibility of having the salvage of this myocardium is great. And this is a German study which is shown in the slide on the left side of the slide. And as you see here, the sensitivity and the specificity is very high in patients who are responding to gadolinium. Now let us take a case which illustrates this feature of CMR application. So this is a 51-year-old gentleman with prior myocardial infarction and a non-ischemic cardiomyopathy presenting with dyspnea and fatigue. He sustained several myocardial infarctions in the past. He's having now angina and rest pain 2 to 3 times a month, and is on oral nitrates. His vital signs is all right. His jugular venous pressure is 5 centimeters, that's normal. He's having an S3 and S4 gallop and a systolic murmur over the apex. He's under consideration not for defibrillator in replacement, but for resynchronization therapy. But prior to that, the treating physician wants a viability study. So that's the situation. This is an apical 4-chamber view. This is the left atrium, left ventricle, septum, the right ventricle, right atrium. If you look into the septum here, there is no delayed gadolinium enhancement at all. But if you look into the inferior wall and the apex, there is almost 100%, definitely more than 75% delayed gadolinium enhancement. But look at the basal part. The basal part is less than 50% delayed gadolinium enhancement. So is that viable or not viable? So this was tested by gadolinium dobutamine infusion. It's better, obviously, to be seen and observe the results in real time. But even here, you will find that this area remained akinetic despite dobutamine, so that it's not viable, and so revascularization will not help such kind of patient. So that's how we use multimodality imaging to come to a conclusion and about the viability of these patients. The gold standard for viability is obviously CMR, but sometimes you need the help from other imaging techniques to finalize unanswered questions by CMR. Now, if you look to a patients with hypertrophic cardiomyopathy, this is an end diastolic picture. This is an end systolic picture. And again, there is some delayed enhancement here. So with delayed enhancement, anything is white is bad. Not necessarily dead, because in acute myocardial infarction, you can get enhancement. But as the myocardial infarction heals, you get diminution of the amount of the enhancement. So if you look into this, there is enhancement. If you look into this picture, this is an area of delayed enhancement here. And if you have delayed enhancement in patients with hypertrophic cardiomyopathy, then the prognosis is bad. If you compare patients without enhancement to those with delayed enhancement, the survival is definitely poorer in patients with delayed enhancement. And there is a possibility that the occurrence of sudden death is more with these patients. Now we move to another case. This is a 27-year-old chap with chest pain and a troponin of 10 nanograms per milliliter. Look at the pictures. Now, if you look at the picture, then I will come to the picture again. The question is that an anterior myocardial infarction, or inferior myocardial infarction, or posterior myocardial infarction, or cocaine-induced cardiomyopathy, or myocarditis? Now let's go back again to the picture and we see why. This is a delayed gadolinium enhancement. This is a 3-chamber view, left atrium, left ventricle, aorta. And there is a delayed gadolinium enhancement occurring all the way, taking the basal part of posterior left, inferior left ventricle, as well as the anterior part of the left ventricle. But the important thing is the pattern. The pattern of delayed enhancement is not subendocardial, it's epicardial based. So an epicardial base cannot be ischemic in origin. So this is a typical finding of myocarditis. So in myocarditis, you can get a delayed gadolinium enhancement, and this delayed gadolinium enhancement, the important feature which makes the diagnosis of myocarditis is that it's epicardially based. You get a perimyocarditis. So this is different from the endocardially based delayed gadolinium enhancement, which is characteristic of ischemic. Obviously, if ischemia gets much more perpetuated, then it changes from subendocardially based delayed gadolinium enhancement to transmural delayed gadolinium enhancement. But sometimes the myocarditis changes into mid-myocardial as it evolves into the fibrotic stage. So this is the picture with a healed myocarditis, a chronic cardiomyopathy. You get a mid-wall enhancement. So this is a mid-wall enhancement. Sometimes it involves the whole myocardium, as you see here in a patient with a previous myocarditis, now in dilated cardiomyopathy. You can sometimes get it in 10 to 15% of patients with ischemic cardiomyopathy. But in non-ischemic cardiomyopathy, sometimes it even tells you about the underlying etiology. So if you have the septum predominantly involved, usually this is a herpes simplex virus infection and carries a poor prognosis. On the other hand, if it's a posterobasal involvement alone, then it's usually parvovirus 19 and carries a relatively benign prognosis. So another case, 65-year-old woman, 1-year history of progressive dyspnea. She notes leg swelling over the past 9 months. She has mild hypertension, no diabetes. Serum creatinine is elevated, 1.6. Calculated estimated jugular glomerular filtration rate is 39. So this is an echocardiogram showing the mitral flow pattern. As you see here, the E wave is prominent and the A wave is less prominent than the E wave. If you look into the tissue Doppler, this is the movement of the lateral part of the mitral ring. It's less than 10 centimeter. And if you look into the septal E wave, it's less than 7. So this constitutes two criteria of diastolic dysfunction. If you divide the E wave in the mitral flow by the mean of the lateral and the medial E prime, it's here more than 14. So this is the 2 of the 4 criteria, which are the 2015 guide recommendation for estimating the diastolic dysfunction. So if you have just the 2, this is an indeterminate finding. If you have less than 2, then there is no diastolic dysfunction. If you have more than 2, you have diastolic dysfunction. So this is just in the indeterminate phase, but look at the next part of the study. This is a 4-chamber view with a speckled appearance. Now, if you look into this image, you will find this is a massive pleural effusion. It's a T2 study. Remember, T2 likes water. So whenever you find a T2 study and there is brightness and a highly intense signal, then under these circumstances, you diagnose the presence of water. So this is the apical 4-chamber view. But if you look into the lower picture here, you will find a delayed gadolinium enhancement occurring all through the myocardium. So what's that? If you even look into this picture, it's even more clear all through the myocardium. Sometimes it involves the right ventricle as well. So the question is, I will come to the picture again. What is that? Is that a large infarct involving multiple coronary territories? Is it sarcoidosis? Is it amyloidosis? Is it subendocardial fibroelastosis, or is it myocarditis? The correct answer is that it is an AL amyloidosis. It's not only amyloidosis, but it's you can specify the type of the amyloidosis. This is not the pattern of transthyretin amyloidosis. So in AL amyloidosis, which is due to a plasma cell abnormality or plasma cell dyscrasia or multiple myeloma, under these circumstances, you get deposition of the amyloid tissue or through the subendocardium. So a diffuse subendocardial delayed opacification or delayed enhancement is almost specific. It's very important now not only to diagnose amyloidosis, but identify the type of amyloidosis, because in AL amyloidosis, the treatment is anti-plasma cell chemotherapy, and sometimes you resort to combine the bone marrow transplantation and heart transplantation. Isolated heart transplantation in patients with amyloidosis is usually a failure because of recurrence of the amyloid infiltration in the transplanted heart. But if you combine it with concomitant bone marrow transplantation in AL amyloidosis, you get a better result. On the other hand, transthyretin amyloidosis comes into two flavors. It comes in the mutated form, which is mutated ATTR or transthyretin mutated form. And in these circumstances, you elect to give it medical therapy, tafamidis, we mentioned it in the subject of amyloidosis. If you have the wild type, this is senile amyloidosis, and this responds very well to combine the hepatic and cardiac transplantation. So because of the divergence in lines of treatment, you ought to identify exactly what kind of amyloidosis. So this is amyloidosis and this AL amyloidosis. We will come at the end of this presentation to transthyretin amyloidosis. It cannot be detected by delayed enhancement because it's not insensitive. But the important thing about transthyretin amyloidosis is that it's patchy and it is basal, not circumferential as in AL amyloidosis. It's patchy and is basal. So this is the differentiating point. So it's important to remember, if you forget everything, you have to remember this picture. The three causes of congestive heart failure that produce different patterns of diagnostic delayed enhancement is here. An epicardially based delayed gadolinium enhancement signifies myocarditis, and subendocardially based delayed gadolinium enhancement connotes the presence of a myocardial infarction, and a circumferential location of the delayed enhancement denotes AL amyloidosis. So this is a little summary of what we just mentioned. Sarcoidosis as well as Chagas disease, obviously they are not so common in our country here, but abroad they are not rarely encountered. But the important things about sarcoidosis is that it is patchy and it is basal. So you get delayed gadolinium enhancement here in different areas, particularly near the base of the heart. Remember, in amyloidosis, in the early stages, you don't need to see circumferential enhancement. Part of the circumference alone might be involved, which creates some confusion. But obviously, we are not looking to pictures alone. We are looking to the picture and putting it in the context of the whole clinical situation, as in other forms of cardiovascular investigations. So sarcoidosis is patchy. Sarcoidosis is a granuloma which ends up with fibrosis. If you look by T2, you see edema, you see water. So you detect the active inflammation. Remember, in the nuclear lecture, we talked about the sarcoidosis as taking the 19-fluorodeoxyglucose in the active granuloma. But if the granuloma heals, it shows delayed hyperenhancement by T1 imaging. So under these circumstances, you can detect how much is active inflammation, how much is fibrosis. The immunosuppressant, steroids, and the immunosuppressant obviously are going to attack and try to treat the active granulomatous inflammation, but not the fibrosis. Again, biopsy is not helpful in sarcoidosis because of its patchy nature, but still, if you are not sure of the diagnosis, you can take biopsy from areas of delayed hyperenhancement of granulomatous inflammation. So it's a combination of delayed gadolinium enhancement as well as the T2 imaging, which shows the active granulomatous inflammation that helps the diagnosis of sarcoidosis. Remember, for arrhythmia and sarcoidosis, including heart block, we don't put a pacemaker, we do put an ICD. Now, this is a cartoon which summarizes all what we said. So if you are dealing with an ischemic situation, the delayed enhancement will occur essentially subendocardially as ischemia advances and you get much necrosis. It changes from subendocardially based to a transmurally based. In the non-ischemic situations, you get a mid-wall delayed gadolinium enhancement in patients with idiopathic dilated myocarditis or a progressive form of idiopathic dilated cardiomyopathy or a progressive form of myocarditis. In hypertrophic cardiomyopathy, you get it in various parts of the left ventricular wall, particularly areas that show hypertrophy. Areas that show hypertrophy in hypertrophic cardiomyopathy show diminished contractility and show fibrosis by MRI. And again, you get delayed enhancement in areas where the right ventricle gets inserted into the left ventricle. You get patchy mid-wall fibrosis, delayed enhancement, essentially in sarcoidosis, but again in Anderson-Fabry's and Chagas disease. So Chagas disease, again, is patchy and basal. Sarcoidosis is patchy and basal. Anderson-Fabry disease, which is an alpha-galactase deficiency, is a treatable disease. Obviously, the replacement therapy is very, very expensive, but it is there. And Anderson-Fabry's disease is a deposition not of amyloid tissue, but of sphingolipids in the myocardium, including the endothelium of the coronary blood vessels and the kidney and the skin. Again, it's a diagnosis by biopsy, but CMR paves the way towards that. A subepicardial based delayed gadolinium enhancement is almost characteristic of myocarditis. It can rarely be encountered in the other three, which are commonly mistaken for myocarditis, sarcoidosis, Fabry, as well as Chagas disease. And the circumferential delayed gadolinium enhancement obviously denotes AL amyloidosis. It can be encountered again post-cardiac transplantation as a sign of rejection or an early sign of rejection, but obviously is not the final arbiter in the diagnosis of ejection. Now the question is delayed gadolinium enhancement so specific and so sensitive to detect fibrosis? The answer is no. So what's coming up? What is coming up is mapping. Mapping is actually a more refined method by which we can detect fibrosis. So with weighted images means dependent on, if you say T1 weighted images means that it is an image which is dependent on the characteristic T2 of the tissue. So T2 weighted imaging or mapping, it is an increased signal in patients who are having a localized water collection, inflammation, or acute injury. T2 star means iron, and I will come to that. T1 mapping or T1, I will come to the explanation of mapping now, is non-specific. It can denote either cell injury, extracellular fibrosis, or infiltrative disease. So I would just wanted to call your attention to the word weighting. Weighted means that the picture which you are taking is dependent on T1, T2, or T2 star. Now this is a cartoon which shows the effect of water, and if you have an increased amount of water, then T2 weighted imaging will show progressive increase in the signal intensity. Remember, T2, when it gets T2 is the time for the dephasing of the protons. And as a result of that, if you get anything which lengthens that time, you get more signal and more brightness. And this is exactly what is seen in these conditions. You get more brightness. So if you have an inflammation, water collection, acute infarction, water collection, you get more brightness with T2. Same applies to you. So this can be encountered in acute myocardial infarction. Increased vessel permeability produces water, inflammation, or infiltration if it's an acute process. Now, in cardiomyopathy, you get severe myocardial ischemia, probably because of unique combination of a high intensity. There is no delayed gadolinium enhancement because there is function. If you get this combination, it's almost diagnostic of Takotsubo cardiomyopathy or stress-induced cardiomyopathy. If you get a positive delayed gadolinium enhancement, this means that a myocardial infarction has happened and the prognosis will be worse. But the combination of a positive T2 weighted imaging and a negative delayed gadolinium or late gadolinium enhancement usually connotes a big Takotsubo cardiomyopathy with eventual recovery, and after 6 months you can stop the treatment. Now, this is a hemochromatosis. As you know, this is an autosomal recessive. Not all cases are recessive, but the large majority are due to the mutation of the HFE gene, which allows the absorption of iron. Under these circumstances, you get iron deposition, which creates a magnetic heterogeneity. And this, if you measure it by a certain type of T2 called the T2 star, you will get complete nullification of the myocardium. The myocardium is going to look dark. And the degree of darkness of the myocardium, as you see in this figure, as the intensity as the darkness increases, then you get shortening of the T2 star, specific type of T2. If the T2 star gets below 20 milliseconds, you diagnose hemochromatosis. If it is less than 10, you diagnose severe hemochromatosis. You don't need to correlate that with the liver. We know there is discordance between the amount of iron deposition in the myocardium and the liver and the gonads and the endocrine system, as everybody knows. At the same time, the use of chelating therapy, the sphyrioxamine or the ferripiron, under these circumstances, you can follow up to the effect of the chelating agents in decreasing the amount of iron without the need of biopsy, just by repetitive evaluation of the T2 star timing. The shorter the time, the more the iron are deposited in the myocardium. Now, what about mapping? Because delayed enhancement cannot detect all kinds of fibrosis. What are the kinds of fibrosis? We have two types of fibrosis. We have scar, which is localized fibrosis that occurs, for example, after myocardial infarction. It occurs again after patchy myocarditis. If you look at it with hematoxin and iocine, you will find the scar here indicated by the arrows here. And this is the living myocardium. But we have another type of fibrosis, which is called interstitial fibrosis. And this interstitial fibrosis, the fibrous tissue is interspersed between the viable cardiomyocyte. Under these circumstances, if you look up here, if you look into the tissue, the localized fibrosis or the scarring, you will find delayed enhancement will show it. But if you look into diffuse fibrosis, the delayed enhancement doesn't show it. Actually, not only fibrosis, but also infiltration, like infiltration with amyloid tissue, infiltration with iron, infiltration with sphingolipids, infiltration with anything. If it is interstitial, it evades the power of the delayed enhancement to detect it. So as a result of that, we use different protocol called the look-looker or Morelli protocol, and these protocols are able to identify interstitial fibrosis, which cannot be detected by delayed enhancement. So that's obviously is now in action, now is available, but it's the future of delayed enhancement. Remember, the delayed enhancement, which was introduced by Bob Bono and Ray Kim, was about 20 years old now. So the update is the mapping itself. Now the mapping, if you look into the lower two panels here, this is a small amount of interstitial fibrosis. I hope you see the arrow. But you look at that, at the lower panel. The lower panel you would see much more fibrosis, interstitial fibrosis, than what is seen by the delayed enhancement. So anything green or yellow or red is indicated interstitial. And this is extreme help in identifying these forms of fibrosis, which are commonly encountered in hypertrophic cardiomyopathy, in acute myocarditis, and as well as in chronic myocardial infarction. But again, important finding is that transthyretin amyloidosis produces basal and patchy, not circumferential, basal and patchy diffuse infiltration. So this diffuse infiltration is usually detected by mapping. So as you know here, with little or normal finding without interstitial infiltration through slightly higher and much more higher. The interstitial fibrosis or the interstitial infiltration obviously increases the extracellular volume fraction. So as you increase the extracellular ECV, the extracellular volume fraction, this means that you have something inside it. This something could be infiltration, could be diffuse fibrosis. How can we detect that? By mapping. And the more the extracellular volume increases, the more you get cardiovascular events. So mapping is actually the future of delayed enhancement. It's getting more and more prominent. The most important thing about mapping is that you don't need a dye. You don't need gadolinium. You don't need a contrast. So we know that gadolinium is toxic to the kidney in patients with chronic kidney disease. Under these circumstances, you can't use the gadolinium to find out areas of fibrosis or areas of necrosis or areas of expansion of the interstitial tissue, but you can use mapping, because in mapping you don't need a dye. You need this method, this specific protocols, the lockers and others. Under these circumstances, you can do the job and you get the diagnosis without the use of a dye. So to summarize the situation, cardiovascular magnetic resonance can be used to assess cardiac function and characterize myocardial tissue, both with and without the administration of gadolinium contrast. Patterns is very important. Patterns of 20 years ago, every gadolinium delayed enhancement was considered as a myocardial infarction. Now, as you see from this lecture, that's not the situation at the present. Patterns of late gadolinium enhancement and assessment of properties of T1, T2, and T2 star relaxation, as well as the extracellular volume, can be used to identify the etiology of left ventricular dysfunction in those with cardiomyopathy or infiltrative cardiac disorders. So we stop at this stage and we get questions the way you like. دكتور محمد.
يا دكتور محمد أنا مع حضرتك.
يلا حبيبي. I hope إنه فيش أسئلة؟
حتى الآن لسه.
طيب احنا نستنى. I hope إن أنا أكون واضح يعني. I know إن السبجكت ما هوش commonly touched لكن I think we have في الاسم دلوقتي ناس متخصصين في CMR where they are giving lectures. That will be very helpful.
السؤال بيسأل does late gadolinium enhancement in myocarditis patient mean he will have a permanent scar?
In myocarditis we have doesn't mean ان احنا عندنا permanent scar. انما بتوري ان الجادولينيوم ده ادام موجود بيبقى معناها ان الاكسترا سيلولار سبيس كبير. Gadolinium doesn't enter the cell except when the cells are necrotic. So اذا احنا عندنا الاكسترا سيلولار سبيس كبير بسبب الانفلاميشن والاديمه اللي موجوده، يبقى في الحاله دي هيتحوش الجادولينيوم. قد ايه من الانفلاميشن ده هيروح؟ سبوز ان احنا عندنا بالدواء سحري ستيرويدز فور اكزامبل اديناه وراح الانفلاميشن كومبليتلي. So a later image will show in a delayed enhancement disappeared completely. Suppose ان انا اديت التريتمنت وبعدين حصل انه جزء منه disappeared، جزء منه بقى فايبروزد. الجزء الفايبروزد will take the delayed gadolinium enhancement، فيبقى فيه حته موجوده. قد ايه التريتمنت بتاعي هو الفرق بين الوضع initially والوضع at the end of treatment. Same applies to myocardial infarction. If you have a recent myocardial infarction, T2 image will show a delayed gadolinium enhancement. لكن اللي موجود ايه؟ necrotic tissue، وموجود edema، موجود inflammation as a result of the existence of necrotic tissue. Now with time, edema will be absorbed, the necrotic tissue will remain as it is, replacement fibrosis will still be still. So the amount replacement fibrosis will sit in. So the amount of delayed enhancement will diminish. قد ايه اللي diminish depending about كام قد ايه من الميوكارديوم بقى permanently necrotic. So it's a dynamic process.
Okay. سؤال بيسأل are coronary stents safe regarding the usage of MRI CMR؟
شوف الماتيريال اللي هي any metal is not 100% safe. ده very important. اللي safe هو ايه؟ مثلا الاطباق الورق، علبه كرتون، اي حاجه تانية مش 100% سيف. وخصوصا الحاجات اللي هي فيرومagnetic. ايه هي الحاجات اللي فيرومagnetic؟ اساسا هي الحديد طبعا، والنيكل والكروم. اي حاجه من الثلاثه دول فيرومagnetic. وطبعا الناس اللي بتقرا في كتب MRI هتلاقي ان الصوره مشهوره جدا، السرير داخل في MRI. الماجنت ده is on all the time. يعني مفيش حاجه اسمها الماجنت وقف. يعني اذا انت ناس قفلت وروحت وطفت، الماجنت از اون. سو اذا اي حاجه فيرومagnetic قريبه منه، طبعا انا هاجي للستنت بس عاوز اقول لك الحاجات دي. اذا اي حاجه قريبه منه هتتشفط بالماجنت. طيب هتتشفط ازاي؟ وهي بعيده هتتشفط بسرعه قليله. لكن لما كل ما تقرب من الماجنت السرعه تزيد. ده قانون التربيع العكسي. عشان كده it's very dangerous. So if you have a bullet في جسم انسان او a foreign body in the eye، مش بس هيتحرك to and fro. ليه؟ لان اللي جوه في قلب الماجنت ده هو عباره عن مجموعه من الكويلز، لارج كويلز بنسميها الماجنت كويل، اللي هي بتخلق المجال المغناطيسي. لكن طب مين اللي بيقطع السكشنز دي؟ هي حاجه اسمها جريدينت كويلز. دي الكهرباء فيها بتطلع وتنزل، وعشان كده الحاجات دي بتتغير. فيه على الانترنت سايت يوري كل حاجه بالظبط ايه اللي بيستخدم فيها. نيجي للستنت قبل ما اكمل لان في تكمله. الستنت compatible with MRI، لكن الجايد لاينز بتقول انك انت يستحسن انك تستنى لمده 6 اسابيع. لكن ما هي عباره عن different forms، different materials including stainless steel وكروميوم وكوبالت والحاجات دي هي والالويز منهم، فهي سيف. لكن الجايد لاينز are very cautious للحاجات دي هي. So الحاجات اللي هي الواحد بقى يخاف منها هي الحاجات اللي هي زي الكليبسات اللي بتتحط على الانوريزم بتاع السيربرال فيسلز، انترا اوكولار ديفايسز، الانسولين بامب. الانسولين بامب فيري امبورتنت لانها كلها فيرومagnetic ماتيريال. سو دول فيري امبورتنت انك تبقي cautious about them. طيب احنا بنقسم الحاجات اللي هي in relation to the MRI بنقسمها safe, unsafe and conditional. السيف almost unknown، زي ما قلت لك بنتكلم على حاجه كرتون، حاجه ورق، دول السيف. والانسيف الفيرومagnetic. الاغلبيه بقى كونديشنال. يعني ايه كونديشنال؟ يعني لازم الMRI يكون ليه بروجرام معين والجهاز يبقى ليه بروجرام معين. يعني لما بنتكلم على بيس ميكر مفيش حاجه اسمها بيس ميكر سيف، في بيس ميكر كونديشنال. كونديشنال معناها انك في بروجرام ان MRI مود مخصوص and you take care in the sequencing بتاع MRI عشان تحصل على a safe result. Same apply to defibrillator same apply to the resynchronization therapy إلى آخره. So safety with MRI is very important. ال MRI موجود في أوضة ليه؟ هو ما بيطلعش ionizing irradiation. ال MRI موجود في أوضة، طبعا موجود في أوضة لأن الأوضة معمولة الأرض بتاعتها مقوعة عشان تستحمل التقل الجامد ده، لكن مش ده السبب الأساسي. عشان نمنع راديو فريكونسي ويفز اللي بره إنها تخش جوه. يعني الراديو اللي موجود بره، النور اللي موجود بره، كل ده احنا مش عاوزينه انه يخش، لانه ده هو الراديو فريكونسي اللي بيخلي البروتونز او السبينز تلت في الديفرنت دايركشنز. So remember ان anything needs to be thoroughly investigated قبل ما نحط العيان في الام ار اي. بالاضافه الى الفيرومagnetic الحاجات الثانيه ما هي سيف، هي conditional، وبالتالي and it's ideal انك انت to check everything against الانترنت tables الموجوده. الارتفيشال فالف زي بالظبط زي الستنتس، safe but you have to wait 6 weeks. Not to have, but it's better to wait for 6 weeks. Same applies to the prosthesis مثلا بتاع الهيب ريبليسمنت، بتاع الني ريبليسمنت الى اخره. غيره.
السؤال بيسأل regarding radiation dose safety in children. Which modality is preferable, cardiac CT or CMR?
CMR ما هوش radiation خالص. CMR احنا بنتكلم على magnetic field، ما عندناش ionizing radiation. الاف ام ده عباره عن راديو فريكونسي، دي موجات راديو، دي electromagnetic waves but not ionizing radiation. طبعا السي تي الايونايزنج راديشن كان بروديوس كانسر في الاطفال دول. وي دونت دو سي تي لا للاطفال الصغيرين ولا للبريجننت وومن الا لو كان الريزلت اوف ذا test by any other method. But you can do CMR. Usually you give the infants والكلام ده هو general anesthesia. We don't recommend the CMR في الاكيوت سيتويشنز، لان البور ده بور طويل والعيان كولابس. يعني مثلا لو انا عندي acute aortic dissection in the acute situation CT not MRI، لان العيان ممكن يديفلوب myocardial infarction ويديفلوب شوك وهكذا، يديفلوب extension of the dissection. لكن الفولو اب يبقى ب MRI، لانك انت مش كل شويه هتعرض العيان ده هو لايونايزنج irradiation. So the MRI is not ionizing irradiation. These are two separate things. ال MRI tissue characterization مش موجودة في السي تي. Maybe in the future تبقى موجودة، لكن at the present time ما هياش موجودة. فهو ليه ميزة إنه ما هواش ionizing irradiation، ليه ميزة إنه هو you can get whatever sections you want، ليه ميزة إنه هو بيوري tissue characterization، لكن ليه عيب السي تي يغلبه فيها. You cannot form a 3-dimensional structure من ال MRI. You can do that 3-dimensional and 4-dimensional من السي تي. So طبعا بالإضافة إلى الافيلابيلتي بتاع الجهاز والافيلابيلتي بتاع الاكسبيرينس، لازم تعرف إيه اللي بيستخدم في كل حاجة، إيه التوب برايورتي في كل حاجة، MRI ولا سي تي. If you ده الجنرال بودي particularly in cardiology. يعني مثلا لو بصينا بالنسبه للبون، الكورتكس is better seen، البون كورتكس is better seen by CT، لكن البون مارو is better seen by MRI. So it depends. Suppose that you are investigating the patients for multiple myeloma because they are thinking of AL amyloidosis, then you need expansion of the bone marrow, MRI. Suppose you are looking for metastasis, including the bone and the heart, then under these circumstances you look for CT. Obviously, this should be in conjunction مع الراديولوجيست. الراديولوجيست عندهم كمية كبيرة من المعلومات ما في الشك، and the cooperation is much better than to work in isolation.
سؤال بيسأل is CMR used in diagnosis of congenital heart diseases?
طبعا. Congenital heart diseases, you need ventricular function in almost every condition. So volume and ventricular function. مين الجولد ستاندرد؟ الجولد ستاندرد ده sometimes you don't have complete idea about congenital anomalies زي مثلا الكونكشنز بتاعة الارتيريوفينوس انستموزيس in patients with pulmonary atresia. You need انك انت تعرف الحاجات دي leakage في ماسترد اوبريشن او سيننج اوبريشن. So you need vast amount of information can be obtained in congenital heart disease. هو ده بتاع الانفرنس بقى اللي هو عاوز general anesthesia. But obviously you have to take the idea of the cardiologist as well. لكن you have to have an idea ايه اللي انت عاوزه و what is the ideal method of investigation. الخمس محاضرات اللي احنا بنديهم عن الايفالويشن الهدف منهم امتى انك انت تختار النيوكلير، امتى انك انت تستخدم اكسرسايز اي سي جي، امتى انك تستخدم السي تي، امتى تستخدم الام ار اي، وامتى تستخدم الكاردياك كاثيترايزيشن اللي هي المحاضره بتاع يوم الجمعه اللي جاي ان شاء الله.
اوكي. سؤال بيسأل MRI aortography is it done with dye or without dye؟
MRI we do dark blood and bright blood. الدارك بلاد بنسميه سبين ايكو والبرايت بلاد بنسميه جريدينت ايكو. I didn't want to go into the sequences لأنها it's not required للامتحان ولا الاكشوال براكتس. It's left for the radiologist. لكن السبين ايكو هي الدارك بلاد. الدارك بلاد بيوري المورفولوجي، يوريك الوول اوف ذا اورتيك وول، يوريك الاناتومي بتاع الاورطه من اوله لاخره زي ما انت عاوز. البرايت بلاد بيوريك الفلاب بتاع الدايسكشن، يوريك البريزنس اوف بنتريتنج اورتيك ألسر وهكذا. if you need a cine then we do the steady state free precision او SSFP. ده عباره عن a form of bright blood او gradient echo but in a cine format. ال SSFP is related not to T1 and T1 and T2 but related to the ratio between them. So if you wanted to make a nutshell idea about the different sequences, the commonest هو the black blood which is the spin echo. spin يعني بيدور، هو ده اسم زي ما تقول اسم آخر للبروتون أو للهيدروجين نيوكليوس. So the spin echo, dark blood morphology T1, gradient echo bright blood. SSFP steady state free precision is essentially cine imaging depending on bright blood and essentially used as a reflection of the ratio between T1 and the T2.
Does CMR have any prognostic value in cases of LV non-compaction؟
LV non-compaction is a phenotype، شكل. هل هو تفازن زي احنا كنا فاكرين ان هو essentially تفازن mutation يؤدي الى special form of cardiomyopathy which can be lethal because of arrhythmia. But now the idea changed. It's a morphologic abnormality. It's not a disease that stands as a disease by itself. It can be associated with other congenital anomalies, with different cardiomyopathies. It can be associated with a previously normal heart, and the presentation varies from completely asymptomatic down to sudden death. Obviously, the diagnostic criteria which is present is too short of illustrating the whole story. It's going to change, no doubt. إنما at the present time, we don't consider it as a specific entity of cardiomyopathy ليها etiology ولا ليها clinical presentation ولا ليها outcome. It depends on the concomitant condition and its degree. And despite that, we don't know exactly if the ratio is high between the non-compacted and the compacted myocardium, is that a worse prognosis. Again, we don't know a specific genetic mutation that results from it. And previously we thought that the tafazine mutation is responsible for it, but that's not the situation. Tafferty is just one of many mutations that can result in non-compaction. So remember, in short, it's a morphologic abnormality that doesn't stand alone. Variable presentation, variable prognosis, unstable diagnostic parameters at the present time. If you want to read about it, the best source, but it's extensive source, هو هارست كاتب فيها يمكن 20 صفحة. بس ده ملخص.
Calculation of shunt fraction by CMR, is it as reliable as by right heart case?
Shunt calculation, we don't do shunt calculation now. In ASD, if the right atrium and or the right ventricle is dilated, we have to close the ASD. In VSD, if the left side of the heart is dilated, you have to close the ASD. Patent ductus, if you have a murmur and it's hemodynamically significant, طبعا مش أي patent ductus بيتقفل. Then you have to close it. We don't make dimensions. We make dimensions or degree of pulmonary and systemic blood flow only in conditions in which we are not sure هو ده enlarged ولا مش enlarged، هو بالنسبة لسنه كبير ولا مش كبير التشامبرز دي هي. Obviously, if you increase the amount of blood flow in the pulmonary artery in comparison with the aorta, you get the degree of the shunt. طبعا ده. When we are going to talk about the cardiac output, we don't measure cardiac output, we calculate the cardiac output. عشان تmeasure the cardiac output only in experimental animals. كانت بتتعمل ازاي؟ بتحط مغناطيس around the wall of the aorta and measure the flow of the blood, velocity of flow of the blood. فهو الاساس في الميجرمنت بتاع الكاردياك اوتبوت هو المغناطيس. فيس we can measure the degree of shunt, we can measure the degree of pulmonary blood flow, we can measure the degree of pulmonary aortic blood flow. But we don't usually. Sometimes we do.
آخر سؤال بيسأل is there a valuable role for CMR in diagnosis mechanical complication of myocardial infarction?
كل الميكانيكال complications بتاع myocardial infarction starting for formation of aneurysm, formation, even arrhythmia. I will come to it. Formation of aneurysm, pseudoaneurysm, myocardial rupture, all of them. But the point is, أنا قلتها قبل كده، إنك in acute myocardial infarction، السؤال بيقول acute. We don't take a patient بacute myocardial infarction نحطه في study بتاخد نص ساعة أو ساعة، و if he gets ventricular fibrillation مش هتقدر تعمله resuscitation. So in all acute situations, CMR is not the ideal method of investigation. But if you need information that was not obtained by other methods, then you think about it. But it's not the ideal. It can, but it's not the ideal method by which you could investigate acute situations because of the logistics.
ده كان آخر سؤال.
اوكي. المرة الجاية بإذن الله هناخد آخر مرة هناخد فيها hemodynamics, which was at one time the most important subject in cardiology, still very important. And then we will have من خلال الدكتور الياس البغدادي والدكتور محمد ثابت المحاضرات كلها تتلم و make it by any method available for everybody, free of charge طبعا. So I hope that gets implemented بحيث انها تساعد الناس all through. اوكي
تمام. شكرا لحضرتك.